اوكي، بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Today we'll talk about liver tumors or liver masses. First of all, we'll divide the liver tumors into two types of tumors: the benign and malignant tumors. Okay, benign tumors always discovered and incidentally for other reason, for the patient to do the ultrasound or CT scan for other reason, and then we'll discover the benign tumors incidentally, rarely become symptomatic or rarely become complicated. The most common benign tumor is focal nodular hyperplasia. This is benign tumor, incidentally always discovered. It's more common in the women between 20 and 50 years old, rarely complicated by spontaneous rupture or hemorrhage. The focal nodular hyperplasia does not have a malignant potential for transformation, or doesn't have any risk of bleeding. Okay. The diagnosis by triphasic CT scan is recommended to diagnose or differentiate all types of liver masses. Okay, triphasic CT scan means CT scan with the arterial phase contrast, portal venous phase contrast, and delayed phase contrast. The focal nodular hyperplasia, it is always centrally appeared hypodense. Hypodense, that means it doesn't take the contrast, and there is some area of scarring in the center of the lesion. Okay. As we see here, this is the arterial phase. When we inject the contrast during the arterial, when the arterial phase means when the blood enter the arteries of the liver. Okay. Portal phase, when the blood enter the portal system of the liver. Okay. We see here the lesion during the arterial phase. There is enhancement. That means the lesion takes the contrast, but in the center always there is a fibrosis or scar that doesn't take the contrast. You see here irregular pattern of central of the mass, and also here this is the portal phase, and this is here the delayed phase. Okay. This is other CT scan. We see here the homogeneous enhancement of the lesion and the central scarring. You see how the scar look like. It's a white central and always has a line to peripheral. The other type of benign tumors, it's hepatic hemangioma, which is the most common benign liver tumor in women between 30 and 50s, discovered always incidentally. The large hemangioma, it acts like spleen, where it consumes the platelet and causes thrombocytopenia. We have said in the portal hypertension, there's hypersplenism, where the spleen take make the sequestration of the thrombocytes and red blood cells. Here, with the large hemangioma, we have seen the patient with thrombocytopenia because of this reason. Hemangioma does not transform to malignancy. And the diagnosis always confirmed by CT or MRI with contrast with the triphasic, also triphasic CT scan. Okay, it's always nodular in the peripheral. Okay, and the enhancement always in the peripheral with nodular pattern. The biopsy is contraindicated in the patient with the hemangioma because risk of bleeding. If the lesion more than 5 centimeters, we'll go for further follow-up every 12 months. The surgery is not indicated for not for all patients, but if there is a large hemangioma more than 10 centimeters, or if there is a persistent symptoms like abdominal pain or discomfort or nausea or vomiting. Here it is, the triphasic CT scan. We see here nodular, peripheral nodular enhancement of the contrast during the arterial phase, also with the portal phase, but disappeared during the delayed phase. Here, more clear triphasic CT scan. This is large hepatic hemangioma with irregular enhancement or irregular enhancement during the arterial and portal phase, but isodense with the delayed phase. Hepatic adenoma. Hepatic adenoma, it's rare tumor, but fortunately, the only benign tumor that has the risk for transformation to malignancy. Okay, there are risk factors for all hepatic adenoma: oral contraceptive pills and anabolic steroids. It's really related to the all steroids and contraceptive products. It is asymptomatic if it's less than 5 centimeters, and we manage it conservatively by doing CT scan every 6 to 12 months. Okay, every patient who discovered to have hepatic adenoma should stop the oral contraceptive pills and all other medication that contains the anabolic steroids. Okay, including the IUD, intrauterine devices. The surgical resection, always for the benign tumors, the surgical resection indicated only if the mass make symptoms like abdominal discomfort, nausea, vomiting, or abdominal fullness, or if it's increasing progressively. For the benign, for hepatic adenoma, if it's more than 5 centimeters, it's recommended to do surgical resection because it's a risk for transformation to malignancy. Okay, and in male also, it's a risk for it's a potential for transformation to malignancy. Hepatocellular carcinoma. Hepatocellular carcinoma, which is the most important in this, the most important cancer or mass in this lecture, and it is common in all exam. It's common in your daily life practice. It is very common in the patient with the liver cirrhosis, and the risk factor, the only risk factors for hepatocellular carcinoma is inflammation, chronic hepatitis, and liver cirrhosis. And that's why every patient with liver cirrhosis or chronic hepatitis should go for ultrasound surveillance every 6 months. Ultrasound surveillance every 6 months. This is important. And for every patient who discovered to have liver cirrhosis should have an ultrasound we can say ultrasound of the basic. After that, we'll do further ultrasound for regular surveillance. Okay. It is one of the major cause of decompensation liver disease, and if in every patient who has was admitted for any cause of decompensation, we need to have an ultrasound for rule out any hepatocellular carcinoma. Okay, any patient with liver cirrhosis and who develop all of a sudden loss of weight and loss of appetite or right upper quadrant pain, we should rule out the hepatocellular carcinoma because it's alarming signs. The diagnosis, the only cancer that can be diagnosed without a biopsy is the hepatocellular carcinoma with the triphasic CT scan. Alpha fetoprotein is no longer used for screening or surveillance because of poor sensitivity. We use it for just follow-up of treatment. The hepatocellular carcinoma, it takes the the origin of cancer is arterial. Okay, the origin of cancer is arterial. That means it takes the product or the contrast during the arterial phase. You see the whitish color of the cancer, and during the portal phase, the liver, usually 70% of the liver take the blood or the blood supply during the portal phase, portal venous phase. We see here the contrast. The contrast, it leaves the mass, but the liver, it's white. And during the delayed phase, there is no contrast, neither in the mass or in the liver. Is it clear? That makes sense or not? Does that make sense? Hello? Shabab?
دكتور ممكن تعيد؟
Yes. Okay. The liver normally, the blood supply 70% during the portal take the blood supply from the portal system, 70%. صح ولا لا? And 30% only from the arterial system. Okay. When we inject the contrast during the portal venous phase, when the blood go through the portal vein to supply the hepatocyte, we see here the contrast. The liver is white now, right? صح ولا لا؟ واضحة هنا. But here it's gray. Here it's gray. Okay. But during the arterial phase, the mass, it's different from the liver cells. It's different from the liver cells. It takes the supply during the arterial. It takes more arterial supply than portal supply, and that's why it is now taking the contrast during the arterial phase. Okay, clear now. هذه نسميها wash out. wash out. أن الليفر الآن ما ياخذ الكونتراست لأنه الارتيريال، لكن هنا ياخذ الكونتراست لأنه البورتال 70% ياخذ during البورتال من البورتال فينوس، لكن الارتيريال بس ياخذ 30 إلى 25%. هنا نشوف هنا during الارتيريال الكونتراست، التيومر ياخذ الكونتراست. هنا التيومر حصل واش اوت، يسمونه واش اوت، يطلع الكونتراست طلع برا during the portal phase. But during the delayed phase, it's the contrast will leave the liver and the hepatocellular carcinoma. We see here, this is without contrast. This is the arterial phase. We see the liver. we see the liver taking the contrast. The liver doesn't take the contrast, while the mass taking the contrast during the arterial phase. Here is the opposite. We see the washout. The contrast goes out of the mass and as taken by the liver cells, normal liver cells. Okay, here's the delayed phase. We call it washout. Okay, cholangiocarcinoma. Cholangiocarcinoma is a mass of bile duct. Is a cancer of bile duct. Okay, cancer of bile duct, either intrahepatic or extrahepatic. Okay, most patients with extrahepatic cholangiocarcinoma present with jaundice because of compressive effect of the mass and pain in the right upper quadrant, or weight loss or loss of appetite. The patient with intrahepatic cholangiocarcinoma less commonly to present with the jaundice. PSC, primary sclerosing cholangitis, is a risk factor for cholangiocarcinoma. Also, triphasic contrast enhanced CT scan could diagnose the cholangiocarcinoma. For the distal extrahepatic cholangiocarcinoma, we see intrahepatic and extrahepatic dilatation because of the compression of the mass to the bile duct. While the perihalar cholangiocarcinoma, we see only the dilatation inside the liver. Intrahepatic cholangiocarcinoma, usually it's a mass in non-cirrhotic liver. Okay, we see here if it's extrahepatic, the compression here and dilatation more proximal, while the perihalar, the compression would be here and the dilatation would be proximal, while the common bile duct is normal, not dilated. But in the intrahepatic, there's no dilatation of the perihalar or common bile duct. This is a CT scan with the triphasic contrast. CT scan with triphasic contrast for the cholangiocarcinoma. It's not really interesting for a fourth-year medical student, but you should know the symptoms and signs of cholangiocarcinoma and how would you differentiate between the three types of cholangiocarcinoma. Also, the hepatocellular carcinoma is very, very essential and important to understand it. Okay, all patients with suspected cholangiocarcinoma should have tumor markers like CA99 and CAA, and also for intrahepatic lesion, alpha-fetoprotein for differentiate the hepatocellular carcinoma from cholangiocarcinoma. Okay, this is a case of 36-year-old woman brought to emergency department being involved in motor vehicle accident. She's alert, awake, and oriented. There is no family history of serious illnesses. Temperature normal, pulse 100, and respiratory rate 20. Blood pressure with a normal. Physical examination show ecchymosis in the trunk. A fast scan is negative. X-ray shows no fracture. CT scan with enhanced contrast show 4 centimeter sharply defined mass with hypo-attenuated central scar. That means what? Focal nodular hyperplasia. Which of the following is the most appropriate next step of management?
See a doctor, discontinue the oral contraceptive.
I would not say that. I would say reassurance and observation. because it's not hepatic adenoma. Okay. A 33-year-old woman comes to physician for follow-up examination. She was treated with the urinary stone 1 year with medical expulsive therapy. There is no personal family history of serious illnesses. Her only medication, oral contraceptive pills, taken for 12 years. She appears healthy. Physical examination, no abnormality. CBC, serum creatinine, electrocytes within normal range. Urine analysis within normal limits. Ultrasound of the abdomen well demonstrated hyperechoic 3 centimeter hepatic lesion. CT scan with contrast demonstrate 3 centimeter hepatic lesion with peripheral enhancement and subsequent centroparietal flow followed by rapid clearance of contrast. هذه ايش؟ هذه ممكن تكون هيمانجيوما صح؟ صح؟ لأنها فيها peripheral enhancement. Okay. Peripheral enhancement. In addition to stop oral contraceptive pills, which of the following must operate next step management? الإجابة هي شباب
سي يا دكتور.
سي.
repeat imaging in 6 months. أحسنت. هنا 45-year-old woman comes to physician because of 3 months history of mild right upper abdominal pain. She has no had any fever, chills, or weight loss. There is no personal or family history of serious illnesses. Medication include estrogen, transdermal, and recently started for abdominal examination show no abnormality. Ultrasound, liver show well demonstrated demarcated homogeneous hyperechoic mass surrounded by normal liver tissue. A biopsy of lesion would put this patient at greater risk for which of the following complication?
اي دكتور.
A. أحسنت. Intrahepatic intraperitoneal hemorrhage. This one has been discussed, I think. Okay, 55 years old man comes to physician for follow-up examination during the past month. He has had mild itching, alcoholic cirrhosis, hypertension, GERD, vodka, quit 4 months ago, current medication, Bramipril, isomeprazole, vitamin B, appear thin, his temperature within normal, pulse normal, blood pressure normal, examination show reddening of the palm, that means he has cirrhosis bilaterally and several telangiectasia over the chest, pressed bilaterally, enlarged, his testes are small and firm on palpation. Laboratory studies show hemoglobin 10 and platelet 89. What does that mean? Platelet 89. Albumin 3 gram. Bilirubin is slightly elevated. Alkaline phosphatase normal. AST, ALT normal. Alpha fetoprotein is normal. IgG anti hepatitis A virus positive, anti-hepatitis B S antigen, surface antigen, or antibody, عفوا. Upper abdominal ultrasound shows nodular liver surface with atrophy of right lobe of the liver, and upper endoscopy shows no abnormality. Which of the following is the most appropriate next step of management?
E.
Repeat ultrasound in 6 months. أحسنت. Okay, is this the same? Yeah, this is the same.